Good afternoon to you all. I welcome you all to the third symposium in the College of Surgeons 2020, the title Towards Excellence in Trauma Care. According to WHO Global Status Report 2018, annually there were 1.35 million deaths occurred due to the road traffic accidents. It ranked 8th place in all-age mortality with 2.5%. It is the leading cause of death between 5 and 29 years of age. Death rate is 3 times higher in low-income countries in comparison to high-income countries. According to the expert reports, close to 2 million lives could be saved out of 5.8 million deaths annually due to injury by improving trauma care in low and middle-income countries. In 2018, National Hospital Sri Lanka reported 67,000 trauma-related admissions, and out of that, 460 people died. I hand over to my colleague, Dr. Kirthi Abayajeewa, to introduce our three renowned speakers of trauma care.
Thank you, Amila. So the first speaker will be Dr. Razek, who will be, Dr. Tarek, who will be speaking on team-based training in critical cases of trauma. Dr. Tarek is a trauma surgeon and intensivist who is the current director of the adult trauma program at the McGill University Health Center. He completed his surgical training at the McGill University and his trauma surgery fellowship at the University of Pennsylvania. He is a co-director of Center for Global Surgery at the McGill University, and his actively participates in the surgical and trauma development programs in Tanzania, Rwanda, Mozambique, Ethiopia, Malawi, Ukraine, Haiti, Chile, Uruguay, Nepal, and Mexico. Over to you, Dr. Tarek, for your speech.
Hello. My name is Tarek Razek, and I'm the Director of Trauma at the McGill University Health Center in Montreal, and I'm also the co-director of the Center for Global Surgery. And it is a great pleasure for me to join everyone virtually here at the College of Surgeons of Sri Lanka. I'm very grateful for the invitation to present to you, and very sad that I'm not able to be there in person, but very happy I'm at least able to share this time with you together. My topic is team-based training in trauma. So in a very short period of time, I will try to go through some of the elements that are critical in enhancing our capacity to perform as teams, why this is important to trauma systems and critical care overall, and how can we improve our capacity to perform in a team-based environment, which is our normal working environment. So I'm going to review the importance of teamwork, the importance of team training as it pertains to trauma care specifically, but really as it pertains to all critical medical care that we do, both in the emergency department with receiving critically ill or injured patients, and in the operating room as well, as we try to work together with complex teams and perform difficult tasks with interdisciplinary groups of people performing at high levels, and how we can work together, globally speaking, to collaborate to improve our capacity. When we work together as teams, the impact can be quite dramatic. Prior to introducing complex trauma systems where we work together as teams, we did not have the ability to improve outcomes to the degree we would like to see. When we work together as teams, which is what a regional trauma system of care is, hospitals working together, doing what they're able to do, moving patients down an echelon of care from smaller facility to larger facility, dependent upon good assessment of the patient's situation and the patient's need for specific types of care. When we integrate this system together and we all work together, not just between hospitals, with our EMS pre-hospital teams, and within our larger hospitals working together with complex multidisciplinary teams, we see improvements in mortality by about 15 to 20%. The majority of that impact is the implication of working together better as teams. So this concept of teamwork and team integration is truly critical to enhancing performance in our care, especially when that care is in more critical situations. These systems of teamwork go even beyond clinicians. I won't have the time to get into many of these aspects of working together in even broader teams, but then our complex clinical teams that we have to work together with, which is challenging enough to work together appropriately as groups of different specialty physicians and surgeons, interdisciplinary teams with nurses of different specialties, technicians working together with us, and our EMS pre-hospital teams as well. This integration goes beyond even the hospital-based care into injury prevention, rehabilitation on either end of the spectrum. Obviously, we're going to focus here on hospital-based teams as I describe a bit more how we can improve our capacity to perform in this way as integrated teams, which allow us to then see those improvements in care and outcome. Underpinning a lot of this is how we all work together in our analysis of our performance. Again, I won't have time to get into this, but it is a critical foundational element of how these systems all work, about collecting data, understanding what is happening in our communities, what is happening with our own teams in our institutions, and how we are performing, assessing that performance objectively so we can track how we are doing over time and therefore be more focused on and targeted in how we are deciding what we intervene on, where we invest time and energy, and what the impact and outcome difference is by virtue of that investment of time and energy in that practice. I'll give you an example from my home in Quebec in Canada. We regionalized our trauma system in 1993. So really not all that long ago in terms of the trajectory of our healthcare system here in Canada. Before then, we did not work in an integrated fashion. We did not have trauma teams. We did not have trauma centers with specialized training for those teams at those centers. We did not coordinate with our pre-hospital teams and with our smaller hospital facilities in our regional environment, the identification of specific patients who surpassed their capacity to provide life-saving definitive care. We did not integrate this together. We did not have echelons of transport. We did not have coordinated protocols for how to move patients through the system. We did not have designated trauma teams that are even referral trauma hospitals, which were not even designated as trauma hospitals. We changed all of that in 1993. We designated specific trauma centers. We did focused specific training for the teams housed in those centers to do the complex care that we are able to do in those larger hospitals. We also trained teams in our smaller hospital facilities to be able to manage how those teams function together. Mortality was 50% before we did this for major trauma in my region of Canada. Really quite not a great result, and we were unaware of this when we were beginning the assessment because we had not collected the data. So the data is key to understanding our performance. After implementation, 5 years, the mortality dropped to 18%. 2002, 9%, 2007, 6%, and now it stands at around 4 to 5%. So the impact of this team structure and integration cannot be overstated, I don't believe. We don't work alone. I never take care of a critical trauma patient or any critically ill patient in my practice in intensive care medicine or trauma surgery alone. I work with a large team. As my children always point out to me, it's important to work as teams in our family unit. It's important to work as teams in our professional work as well. Much of our training, though, is focused on our professional expertise, not in the team, but in our area of expertise. So ATLS is a great example. Advanced Trauma Life Support is a phenomenal example where we examine our performance and we improve our training and capacity in our core area of work. As a physician, for example, with ATLS. Fabulous course. I'm responsible for ATLS in my region of Canada, and it's fantastic training that we all have to have the underpinning of our specialty-specific knowledge and skills. But it doesn't address how we integrate together as teams. As I said, we always practice together as teams. So how do I take that knowledge of what I'm supposed to do as an individual physician or surgeon, and how do I deploy that as a team leader for a large multidisciplinary team of other specialty physicians and my nurses and technicians that I work with indispensably in taking care of the critically ill and injured. So we have designed some courses that help us to train our team members how to function better within that team unit, how to be a team leader, how to be a team member, and how to take the knowledge I've acquired as a specialty individual in my own area of work, and how do I apply that in the team? How do I work together that way? One of the programs we're very proud of is the Trauma and Disaster Team Response course that we work through here at our center. These are the objectives. You can see how they add to what the training we would have received in the ATLS is. They're additive to that. They're synergistic. They allow us to deploy this in the team structure that we actually practically work in day to day. That's really important. You can see all the focus on team and teamwork in this environment here in the objectives. And the team exercise component of the course, we really practically train, simulate, and practice how to do this. Very critical training that we often don't do very well in healthcare practice and training. My experience, and I'm sure it's shared by many in the audience, is we don't spend a lot of time training together in the teams in which we normally provide our work. Here's an example in the program of a trauma team and how you would structure it. This is very flexible and adaptable to the local context. Obviously, local leadership is key as we adapt the material to fit into the local realities of practice, physical resources, human resources. How does it fit into the local context? The course is extremely flexible and adaptable to that local context, which is critical. Another example of this is the Definitive Surgical Trauma Care course sponsored by IATSIC, which many of you are familiar with. This approaches that the same way in terms of working together, training as teams in the operating room environment. Whereas the previous course, the Trauma Team and Disaster Training course, is how we do this in the emergency department. And this team training in different contexts is absolutely critical to enhancing our performance. I'm currently responsible for the DSTC course globally, and we are looking at ways to expand its footprint in the rest of the world. The question then becomes, how do we collaborate in a time of COVID? How do we do this integrated training all together, sharing global experiences all together in a meaningful way? Well, one thing we focus on dramatically is training trainers, focusing on instructor training, course director training, etc., so that we can work together with local leadership to give leadership of the program to the local leadership, which is critical to adapting it to the context and making sure the material is context specific and applicable in the local environment. How do we do that with distance support? Well, we've found that training trainers at distance actually is extremely feasible. People come to the training with a significant degree of capacity already, especially in their core area. And we're just expanding that and supporting the expansion of that to be able to work a little bit better and how to train a little bit better in a team environment. And that's actually incredibly successful with a video support structure. And we've actually had some experience doing this now and are very happy with how we're able to do this, to train trainers, train instructors, train course directors to take leadership of the program collaboratively with us and deploy the programs. We're also looking at very innovative uses of virtual reality training using VR headsets, which are a very exciting way to even expand that capacity to enhance leadership skills, to deploy the programs in many environments around the world and work with leadership teams around the world who collaborate this way to expand access to education and training resources, which are so badly needed for all of our team members in our healthcare systems to be able to perform better and take care of our communities and populations with the outcomes and improvements in mortality we would like to see that we know are directly related to our ability to perform as teams. So I hope I've been able to demonstrate the importance of team and team training, how I think there's a lot of room for all of us in the health community in the world to improve how we do team training together and how we can have opportunities, even in the time of COVID, to work together as leadership teams and instructors and directors and people who are passionate about teaching and training and simulation work and improving outcomes in our communities through that mechanism to work together as a global team. And I'm excited to hopefully work together with many of you in the future in these exciting projects of enhancing team training to improve our performance in our systems. A big hello from Canada, and thank you again very much for the invitation to present today.
Thank you, Dr. Razek, for giving broad overview of team-based training in trauma. And our next speaker is Dr. Mahanama Gunasekara. And Dr. Mahanama Gunasekara is a past president of the College of Surgeons of Sri Lanka, and he has been an active member of the council for the last 14 years. He's a pioneer in establishing the present curriculum in general surgery, which leads to board certification in general surgery with subspecialty interest. Dr. Gunasekara is an experienced trauma surgeon. and is a training national trauma management course who has attended to large number of civilian and combat injuries during the armed conflict in Sri Lanka. He has served in many parts of the island of Sri Lanka and introduced laparoscopic general surgery to several regional hospitals. Presently, he is a senior consultant in National Hospital Colombo and an honorary senior lecturer of the Faculty of Medicine Colombo since 2015. Over to you, Dr. Mahanama.
Thank you very much, Chairman. And firstly, I would like to welcome Elmin and then Dr. Tarek Razek to Sri Lankan Congress, and we are really grateful for your contribution to this this Congress, although we are sad that you can't join physically. I'm going to give a little overview of the statistics of Sri Lanka, and then, of course, what we are to do in the future to improve the quality of trauma care in this country. It's a beautiful land, but we are not lucky when it comes to trauma. And I saw this publication by the World Bank report in 2019. We have something like the little island with only 20 million population, 65,000 square kilometers, but we have 38,000 crashes per year. That means about 100 road traffic crashes daily, which kills 8 people and injure 22 people minimum, seriously injuring 22 people. And the trauma is a leading cause of hospitalization since 1995. And then the injury pattern of trauma changed while we are experiencing this since the cessation of war in 2009. Road crashes got escalated with the development of new roads, as well as increasing the number of vehicle owners in the country with the change in the economic environment. Therefore, the automobile injuries became the leading cause of major trauma. And you can see how we drive. It's all very safe. And at the same time, these are the 25 districts. You can see the recently developed, liberated areas from the war. The last few, you have very high incidence of road traffic trauma, particularly Mullaitivu district, Kilinochchi, Mana, Hambantota. All these districts didn't have wide, smooth roads like this. So our driving needs to be corrected. So as a result, Sri Lanka has become a leader in the region when you compare to our neighbors when it comes to road deaths. In addition to the war and the road traffic trauma that we experienced, we saw so many things during our lifetime. We saw tsunamis, we saw landslides, floods, and daily basis we see people getting attacked by animals, falling from trees, occupational injuries, and then drowning. In addition to being recently we had a terrorist attack also, even after cessation of war. But one thing is clear, that we don't have data. Although we experience so many things, we don't have data on this. And the available data is either inadequate or grossly incomplete. So when I was asked to talk about what more to be done, the first thing which came to my mind is we need a national trauma registry. I'm happy that Dr. Tarek Razek in his speech highlighted what a national trauma registry is. So that is what we need in order to have an integrated national trauma system, which is a must. And at the same time, we need to train our teams. Not only doctors, at the moment we are conducting some training programs, but we need to train our nursing staff, the surgical team, and of course, transport team in the ambulance crew, and the public and the school children as well. I'm happy Dr. Jayendra Fernando, the current president, initiated this establishing a committee on trauma under the banner of College of Surgeons of Sri Lanka, and we are planning to work closely together with the Trauma Secretariat of the Ministry of Health in order to achieve these goals. And the National Trauma Registry means, as Professor described, is key to a successful trauma care system. And of course, it promotes research, audit, and policy planning. When it comes to the integrated national trauma care system, you can see we established the Trauma Secretariat in 2007 with the aim of developing this pre-hospital care, hospital care, and the rehabilitation and prevention module. But however, the functional results are very minimal, and they do not have any data available to use by stakeholders to develop the system. Some of the domains of the national trauma system was developed, but they were not integrated properly to get the maximum benefit out of it. One is the pre-hospital care ambulance service. We never had a proper ambulance service, pre-hospital care service as such. We had to hire some ambulances from other sources available before 2016. It was established in 2016. Now we have about 300 ambulances roaming across the island. And of course, it is available free of charge to patients. So at least we have a reasonable pre-hospital care service, which certainly there is room for improvement. One is this pre-hospital care system has to be integrated with the hospital care system to improve the outcomes. At the same time, there should be a training module for the pre-hospital care team. And the number of ambulances has to be expanded depending on the timely access needs after proper evaluation. Therefore, we need to evaluate the essential surgical care services availability and access to the essential surgical care, as well as the outcome of those patients in order to improve the pre-hospital care system. And this is based on the Lancet Global Commission assessments, the timely access to a place with capacity to treat, which is safe and affordable. So that is the aim. Lancet Global Commission uses 3 bellwether procedures: appendicectomy, compound fracture, and cesarean section to assess the surgical access within 2 hours. But we need to look at these figures in Sri Lankan context. Now, the first map, this one shows the population-based distribution of surgical care units which are available for emergency services. You can see the Colombo and Dampa, these tiny 2 areas, harbor 5 million of the population, that is 1/4. And you can see the maximum amount of trauma care centers are located in those regions. These districts, which are darker, has more than around 1 million population. They have, again, per surgeon, there are a very large number of patients or population allocated. And similarly, obviously, these are the districts which are least populated and you have less number of surgical care units. And these are the military hospitals during wartime, and the teaching hospitals are located in the island now, like this. And these are the tertiary referral centers with all full facilities like neurosurgery and advanced imaging to provide trauma care. And in what more to be done in this setup? All tertiary care hospitals are not equally equipped. So therefore, we need to look at them and then improve what is absent. And on the other hand, there are hospitals where surgical units are available with the surgeon, anesthetist, and a good trained surgical team and good theater facilities. These hospitals should work as apex hospitals to drain patients from either the site of injury or from the primary care hospitals where there are no surgeons. At the same time, these apex hospitals should be clustered together based on the level of care. There we have 5 levels of care hospitals to provide trauma care with surgical facilities. So this is the basic model, where from the site of injury, you reach a primary care hospital without a surgeon. And from there, you transfer to a secondary level where there is a surgeon, blood transfusion facilities. And if needed, particularly for neurosurgery or advanced imaging, you may have to transfer to a tertiary care hospital. Similarly, either you are directly going into one of these hospitals. So this is a typical of cluster. And you have to see this cluster system based on the hospitals, how it is distributed in Sri Lanka. These are the 5 levels. You can see the apex hospitals where surgical facilities are available. And these are the so many private primary care hospitals run by the government where patients might reach. And almost all these hospitals have ambulance facilities to transfer them into a facility with surgical care. So this cluster system has to be improved so that the transport system has to be adjusted based on the population density and the terrain that they have to travel. Some roads are difficult. And then, of course, available transport facilities has to be utilized, particularly the pre-hospital care ambulance service and the hospital ambulance services should be linked together to have an efficient service pattern. And then, of course, the demography of trauma pattern has to be taken into account to improve the system. And we all know that our hospital system is distributed reasonably well according to the population. However, this 2-hour interval is too long when it comes to the assessment using the Lancet Global Commission criteria. So therefore, we need to look at exactly the outcome of these patients, where what happens to them when they come to the hospital. And these the trauma care facilities should be developed in identified hospitals depending on the number of patients reach each hospital. And similarly, emergency ambulance service has to be linked to other transport systems, and the facilities should be redistributed or add new facilities to improve the hospital care system. The next level is rehabilitation. I'm sorry to say, rehabilitation is one of the poorest areas that is developed in Sri Lanka. So that is, although the treatment, hospital treatment is free of charge at the point of care delivery, it is not so for the aftercare services, where a patient has to bear the entire cost of transport and looking after the patient. So it includes transport to the hospital, nursing care at home, and sometimes they have to go to private sector treatment depending on the close vicinity of the available proximity of their hospitals. And their mental health issues are not addressed at all. And they do not have orthotic devices which are required, or sometimes it is not the suitable ones. So similarly, their re-employment plan and the health expenditure catastrophe has not been assessed. So I will have to shorten my this thing. The second one is what more to be done. So you have to have a project to survey the affected population and identify their needs, disability, and the talents, and facilitate their treatment process, both physical and mental health. And similarly, the occupational rehabilitation, vocational training for re-employment, new employment, or re-employment in the same place, and the research into their requirements, as well as funding which is needed for the insurance, needed for such projects. So this could be obtained from either insurance fees or penalty fees, or whatever the funding has to be worked out. And preventive aspect is beyond the scope of college. We can discuss it in the discussion phase using international model like 5-pillar model that has been suggested by the United Nations. So I will skip the prevention part and go to the training in trauma care, where currently we are conducting National Trauma Care course, ATLS course, as well as the PTC course, and similarly other training modules which include DSTC and definitive management of major trauma courses. However, we need to have...
Mahanama, we need to...
Okay, thank you very much. So I conclude. Thank you.
Thank you very much. Hope the next speaker is Professor Elmin Steyn. She is the chair of Division of Surgery at the Faculty of Health Sciences at Stellenbosch University, and is the head of the surgical services at the Tygerberg Hospital in Cape Town. Elmin is certified subspecialist trauma surgeon and has a vast experience in transplant surgery as well. After spending time in Vancouver, Canada and Denver, Colorado, to gain experience in transplant and trauma surgery and working as a consultant surgeon at California Hospital, Pretoria. She took up a post as a senior specialist and later as principal specialist and the senior lecturer at Stellenbosch and Tygerberg Hospital, where she later was tasked with heading the trauma unit. Over to you, Elmin. Yeah, Elmin, over to you.
Good day. This is Elmin Steyn. I'm talking to you from Cape Town, and I'm going to speak about the challenges faced by providing ideal trauma surgery and trauma care for patients all over the world, especially in developing countries. Thank you very much for this opportunity. I think we all realize that trauma in developing countries is a vast burden and a much bigger burden, according to WHO, than the most common infective diseases of developing countries. At the same time, we know that trauma varies from country to country, and depending on issues at the time, there is a difference in what kind of injuries are seen. But we all know that economy has a very strong influence on what happens to people, especially as far as trauma is concerned. And where there's unemployment and poverty, there's usually also sociological, political, and other inequities such as education and healthcare, and also perhaps not less than ideal governance in some of these aspects. This is associated with a lot more injuries, often transport-related injuries and workplace injuries, which are more of the blunt injury kind, but also interpersonal violence, crime, and even war and conflict, which contribute greatly to trauma in a region. In our region, we deal with a lot of drug abuse, which is associated with organized crime and gangsterism, which brings a lot of gunshot wounds to our hospital. But that's not all. All over the world, there's an increase in terrorist incidents. Very strange and bizarre incidents are being recorded at the moment. A recent beheading of a teacher in France, and strange attacks where people are stabbed in the US and in the UK and various parts of Europe. So a changing profile of terrorist incidents and the kind of injuries that they bring. But that's not all. There's also a very vast change in some continents in terms of the need for people to leave their homes and find new areas to live for them to be able to feed their animals and their children. Especially in the desert that is expanding in the Sahel region. We all know about the bushfires in Australia, but there's also been extensive and prolonged fires in the Arctic, in Southeast Asia, and also in the US, very well shown on the media, but the consequences are worldwide, across the globe. Sri Lanka is very au fait with weather extremes. There's regular disasters, and especially floods in Sri Lanka. And it's one of the countries that's rated amongst the highest when it comes to the risk of extreme weather events. This is a very good publication from our colleagues in public health, and they made an extensive study on the Asian Pacific region and the weather changes, the climate change and the extreme events, and how that affects the health of people in this region. And they conclude that health is affected in many, many ways, and trauma and injury is definitely one of the bigger issues. But most of all, they reflect on the need for us to recognize this problem and start planning. Now, you may ask, how does climate change affect the surgeon? Is there anything we don't know and we haven't seen yet, considering that earthquakes and floods and high winds are not that unusual in many parts of the world? Well, we need to recognize that part of this is no longer regional disaster events. It is also global, and people are changing their patterns. Vulnerable groups are moving across continents, looking for food, looking for places to stay. The poor and the displaced and the hungry are going to be exploited by criminals and fanatics. Politicians find opportunities here to make their power struggles, and then there's a competition for resources. When there's no water, people compete, and it doesn't bring out the best of people. Xenophobia is not something that anybody would like to see in their country, but this is what happens when populations move into other regions. The world has been assessed thoroughly. Risks are assessed every year, and this is an indication of risk in terms of exposure to climate events, as well as lack of resources. And the pink countries are the ones most affected. And you can see that most of Africa is very, very pink, and so is Southeast Asia and the Pacific countries. Sri Lanka is there, and these are areas that are certainly at risk for worse and worse climate events. So what can the surgeons do, and what can surgeons expect in this whole scenario? We're going to see a lot of the things that we are seeing at the moment, but they are going to be more frequent and of bigger magnitude. We know disaster injury patterns. We know that these patients need amputations the next a few days down the line, and we know that they need dialysis. But can we cope with more and more and more of them? And can we also cope with the crime and interpersonal violence that follows? Can we cope with the war and the conflict that is inevitable in some areas? Are we aware of the unusual comorbidities, and are we prepared to see more and more burns? This is the ideal framework for an emergency system. It gives us beautiful graphics on ambulances, on bystanders who've been educated enough to provide emergency first aid. There is a wonderful world with lots of beautiful roads and excellent communication systems, perfect communication between pre-hospital and in-hospital people, excellent training, plenty of staff. All of this is what we all would really want. And this is available, this is known, but few of us will achieve this kind of excellence. So what is the role of a surgeon? We need to be making people aware of the need for a change in our preparation, a change in our resources, and the fact that we will see natural disasters. Yes, we can deal with those, but when we see lots of them and big ones all the time in remote areas of our country, which will be very harmful for the infrastructure and the resources in those areas, can we deal with that? Do we have teams of people who can go there? Do we have more trained ER and OR and ICU staff? Do we have capacity in our emergency departments? Do we have space? These events are going to be more frequent. They won't just be once a year. They'll be once a month. So are we able to deal with that? Are our people trained? Do we have more and more people who are trained in basic surgical skills, basic trauma assessment, and advanced trauma surgery? Our burns units, are they there? Are they big enough? Can they accommodate disastrous burn events? Are our surgeons trained to deal with penetrating injuries, multi-cavity war wounds, multiple gunshot wounds? This is a completely different kind of approach to trauma surgery, and definitely can benefit from DSTC training, for example. And will we be able to deal with the demographics of migrating populations, looking for opportunities elsewhere outside their own countries, where they suddenly become even more vulnerable than what they were before they left their own countries? These are all the things we need to think about. We need to implore our funders, our administrators, to be more aware of the need for much more resources. It's not just going to be once in a while. It's going to be once a week and once a month that we need to activate our disaster plans. So in summary and conclusion, climate change is adding to our evolving trauma burden. And we know that the vulnerable, the ill, the homeless are the people who are going to be most at risk. Infrastructure. Are we aware of this, and are we capable of assimilating these patients? So there's a need for recognition of all of this, and there's a need for capacitation, for training, and for systems to adapt. And most of all, there's also a need for research on the consequences of these events. And above all of that, there's a need to appreciate our trauma care providers and the heroes of this burden, which has gone rather unrecognized up to now. Thank you. Thanks for the opportunity.
Thank you very much, Professor Elmin, for that interesting talk. We have a few minutes for questions. So shall I read one question for Dr. Tarek Razek? On your impressive results on reducing trauma mortality from 18 to 4, the severe category, in trauma team building or team training, what are the aspects that you specifically looked at in building your teams, as technical as well as non-technical skills in the team building, trauma team building?
Yeah, hello, thank you. Yes, that's a very interesting question. I think one of the things we omit to focus on is exactly what the question addresses, is the non-technical skills, or the soft skills, as we call them sometimes, in terms of leadership skills, communication skills, team management skills, in terms of organizing your performance. The technical skill side is obviously also key, but we tend to have a focus on that in our areas of training and work already, and most individuals tend to have decent skill sets in that area, but that always requires improvement and augmentation and reinforcement and maintenance. But one thing that is, I think, in my experience anyway, completely overlooked is the leadership skills, the communication skills, the time management skills, the decision-making skills, how you utilize that technical skill set that we so often focus on exclusively, but fail to focus on how we actually deploy and utilize those skills in actual practice when we're faced with a critical scenario of a very ill patient, even a single very ill patient, which can be overwhelming. And in my experience, you watch junior teams perform under those stressful circumstances, and you see the dysfunction of the team, even though the individuals on the team may be quite good. Dysfunction of the team as a whole to perform under that stress and to integrate their activities together is, in my experience here, often quite poor, and is a huge area of improvement that we've noticed as we focus more on these team building exercises and skills, which enhances the entire performance of the team, and I think significantly improves our ability to deliver the care and deliver the expertise to the patient and integrate it into our system. I think it was beautifully described by one of the other speakers as how important the overall system is to work together. So it's not just the single team in one hospital, although that's very important. It's how we work together as teams between hospitals as well, and within our EMS systems as well, integrating that whole system to provide the care to the patient that's required.
Thank you, Dr. Tarek.
Another one question to Professor Elmin Steyn. With your global experience and developing trauma centers in South Africa, what do you think as a Sri Lankan with the adequate grasp of Sri Lankan system, what do you think, where we have to start in developing trauma system? Is it a trauma centers or EMS or trauma registries? What's your idea about, if you guide us to development?
Well, it seems to me that you already have quite a good grip on the trauma system. Looking at the maps that you were shown on your presentation, there's plenty of facilities. I think core to all of this, once you have and the willingness to provide medical care from your government, then of course we all like more money and more beautiful equipment. But the most vital central core of this is training of staff. I mean, without that, nothing else will work. So widespread training, team training, then focusing on communication and protocols for communication, and then overall strong leadership. And one of the things that we struggle to bring into our systems is the concept of trauma not being one of those conditions that needs to travel from the clinic to the next hospital, to the next hospital, to the next hospital. Administrators, funders bureaucrats, they don't understand that. They understand the medical type of transfer. But for trauma, you need to go to the closest appropriate, even if it's the main hospital, the most advanced hospital. And people don't, it takes a long time to bring that concept to many of the people who make the decisions and who provide the funds. So basically, training, most importantly. Secondly, strong leadership that can speak to administrators, because administrators like to make things work the way they used to. They like to make it fit into the old systems, and trauma is different, and it takes a huge amount of energy to get that message across. I would start there.
Thank you. So my gratitude to all the speakers, Professor Elmin Steyn and Dr. Tarek Razek and Dr. Mahanama for participation and giving us a useful and educative symposium. Thank you.
Thank you. Have a pleasant day.
Thank you.